Okay, and again, common sites, clinical findings, prognosis. Please study this very, very well.
Ahora van a ver a la mujer, a Catalina.
Pero ese man no puede quedar vivo porque ustedes dos se mueren.
Any other questions on squamous cell carcinoma?
Ustedes tienen todos los datos del otro para que le hagan inteligencia.
Cuidado, hijo.
Cuidado, viejito lindo.
Y solamente me pueden llamar de este celular. A mí no me vayan a llamar de otro porque nos caemos y ustedes se mueren, ¿me entienden? Ahí está.
Échate con eso, échate arriba.
So, typically,
Tienen un mes para que adelanten toda esta vuelta, para que investiguen. Pero eso sí, no se
depends where it is, Dr. Wajiha. Depends where it is. First note to be involved depends on where this is. How are questions formulated for this? The question would give you the patient has a SCC,
Que le pague para
T4, and whatever. What stage are they in?
No, no creo que todo.
soy el mejor.
What other questions you guys have? Anything else on SCC?
Pues ya te le digo que tenía que elegir entre Catalina o yo. Mira, Albeiro, yo sé que es Catalina, pero quiero oírselo decir, mucho problema.
Sí, ¿cómo decía la vieja?
No sé, viejito.
Pues sí, señora. Catalina. Pero me de verdad, yo no puedo explicar.
No sé qué explicar.
Amasita hermosa.
Hola, mijo. ¿Y esa alegría?
Marcita, le conseguí para la lavadora para que no gastes más.
Okay, so
Así que se me
there's no questions, then we'll continue on with basal cell carcinoma.
vamos a echar 2 pisos a esta casa, pues.
Byron, cambió para la
Can I
casa.
put the stages again? Sure.
Tienes eso de tatuaje.
Están hablando por teléfono.
Marcita, ¿qué pasó?
Bueno, me hace el favor y me dice a mí dónde sacó esa plata. Me va a decir que se la ganó en un chance también.
No, Marcita, no me la gané en un chance. Y dígame, ¿qué importa dónde la saqué? Lo importante es que le estoy dando platica para que compre las cosas de la casa.
Si no me dice, no la quiero. Porque yo no quiero dinero sucio en mi casa, Byron.
Ah, ¿le parece dinero sucio? Dinero sucio que le trae Catalina cuando viene de esas fincas.
Cabrón, ¿no? Cualquier eso, ¿no?
Yo
Okay.
no saco esta plata mía.
So, basal cell carcinoma, also called rodent ulcer,
Byron, venga.
Hombre, que esté libre de pecado. Que tiene
is the most common skin cancer that we have. Okay, so if we're talking about skin, usually it is BCC first. Okay, so basal cell carcinoma,
Pero es que nunca me doy cuenta que este muchacho se me
then it is squamous cell carcinoma.
Peor de todo es que no sé qué
Oh my
carajos
God,
hacer.
let me try and write this.
Carajo.
So first basal cell carcinoma, then squamous cell carcinoma, and then melanoma. Okay, so this is for skin. For the oral cavity, 90% is going to be squamous cell carcinoma. It's the most prevalent one. There is carcinomas, these subtypes of SCC, followed by other sort of connective tissue and salivary gland malignancies. Okay, so primarily it's SCC. Salivary gland malignancies, mesenchymal tumors, lymphomas, that kind of stuff. Is what's in the oral cavity. Now, so it is again another locally invasive and slowly spreading malignancy. Okay, kind of similar to what we saw in this other thing we had in Verrucous carcinoma. Again, metastases are rare. Okay? it is locally destructive. Okay? Main risk factor is chronic UV radiation exposure. And the most common areas for basal cell carcinoma are the middle third of the face. So middle third of the face, and you have obviously your nose in the middle third of your face. So that's the most common site for a basal cell carcinoma. Basal cell carcinoma is very rarely seen in mucosal sites, like the oral cavity, very rare. A couple case reports, but it's very rare. It typically presents as a non-healing ulcer, so an indurated, non-healing ulcer with rolled borders. So it's going to look something like this. You have an ulceration, okay, and it's got a little swelling and telangiectasia, so these nerves, these veins are a little dilated around it with rolled borders, okay. So typically that's what it looks like, and it's not painful. It's non-healing, sorry. So treatment typically depends on size, okay? So size, typically with smaller lesions, they're easily treated with laser, electrodissection, cryo, with some normal tissues around. So 3 to 5 millimeters of normal tissue margins are needed to make sure that the lesions were removed in entirety. For large lesions or aggressive lesions, typically radical surgical excision and radiation therapy is recommended. Okay, so here's the example again of the ulcer with the rolled borders, telangiectasia. So there's different subtypes of BCC, but this is actually a very common one, the nodulo-ulcerative form of BCC. Which is this right here. It's swollen and it's ulcerated. One more thing here is that we have something called Mohs surgery, which you might have heard of. It's in the notes, or if you go to walk-in clinics and stuff like that, you might see that. So Mohs surgery basically is a frozen section specimen. So in order to explain that, when you take a biopsy of tissues, so when you want to process it with H&E, so hematoxylin and eosin, it takes a lot of time because you have to fixate what you take in a little paraffin block. It takes a lot of time, very time consuming. So you can imagine. And then after that is done, then it's stained, and it takes a really long time to do. If someone is going in for surgery, they don't want to just wrap it up. They don't want to bring this person back again. They want to make sure they remove everything with clear margins of normal tissue. And one way to do that is with this surgery, Mohs. What it does is when they take this specimen, instead of going through that whole preparations to fixate it in paraffin, blah, 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 they freeze it, okay? They take a frozen section, and then they stain it. And the pathologist can take a look and say, hey, you removed enough, like, wrap it up, suture, let's go. Or they can tell them, no, there's still some cancerous cells that we can see in this border or that border, because they will usually label it sutures, so whatever they take out and they label it. So let's say they take this thing out, right? They may label it with sutures. They'll be like, okay, I put a suture on the superior and one on the inferior borders, and then put a different color suture here, or whatever. They will label it, or they will somehow communicate with the pathologist so that they know and say, hey, you know, you put that pink suture, you need to remove a few centimeters or a few millimeters more. Okay, so that's basically what Mohs is. Mohs is a frozen section type of surgery where the surgeon will do that, communicate with the lab. They can easily stain it, see the tissue, get stuff done so that the patient doesn't need to come back for a second surgery.
están empezando a perder las cosas y hasta allá no llega mi tolerancia.
¿Cómo así?
Sí, así. Muchachos, yo no voy a entrar en problemas con ustedes. Mi nombre es
La
Fernando.
ladrona, fue la roba.
Solamente les pido un favor.
Any questions on CCC?
Se vayan.
La Jessica es ladrona, pues.
Jessica, ¿y ahora? Pues robar para que aparezca Mauricio. Ay, no, que nos dijeron que se demora un mes. Eso nos tocará volver a ver qué. Jessica, qué pena con ese señor. Yo le dije a usted que no se fuera a robar nada. Ay, qué pena de qué. ¿Acaso usted no se compró unos zapatos con esa plata? Pues sí, pero esto fue la idea de robarse
Okay.
eso.
So, the next one is melanoma.
Pues.
Hola, Albeiro.
Melanoma is, again, another
Ay,
neoplasm of melanocytic origin, the most deadly form and the least common form of skin cancer.
Leila, por favor, déjeme hablar, ¿sí?
Viene a buscar los temas, sí.
Yo no venía buscando Catalina.
So it can happen on normal skin, meaning it's not preceded by a mole or anything like that, or areas of discoloration or something like that. So it can happen on its own, or there can be a pre-existing lesion that develops into a melanoma. In the oral cavity, it's very uncommon to be seen. Can happen though, obviously. If it does, most commonly it is seen in the palate and the maxillary gingiva. Excessive exposure to UV rays are the primary cause for melanomas, especially the ones on the skin. Oral cavity, they don't know exactly. And racial pigmentation is different, obviously, from melanoma, because racial pigmentation does not change. It's consistent with time. It's always been there. The history is there. We talked about this, I think, earlier on. Whereas melanoma can undergo changes, the A, B, C, D, E, which we will discuss. So, four major types of melanoma exist. One is the superficial spreading, which is most common in the skin, not in the oral cavity, where you have flat and irregular shaped discolorations on the skin. Okay? So most commonly seen on the skin. The nodular, which has the poorest prognosis, because the areas are, as the name suggests, nodular and raised, with dark black, bluish, and bluish red pigmentations. This is another subtype in sun-damaged skin, lentigo maligna, seen in the elderly. In the least common form of the skin, acrolentiginous, which happens to be the most common form in the oral cavity, the acrolentiginous. So, extraoral sites is palm, soles, underneath nails, and then oral cavity. So if you're going to get a melanoma in the oral cavity, it will be the acrolentiginous. Most commonly on the skin, superficial spreading, and these are the other ones. Now, depending on the subtypes, this kind of shows you why there's different prognoses. Melanoma can grow in like a circular-like fashion, so it can exhibit radial growth, so superficially spreading, lentigo maligna, and acrolentiginous all have radial growth. But the reason why nodular has the poorest prognosis is because it can exhibit vertical growth. because it can invade vertically into deeper tissues, and this is why it has that poor prognosis. So there could be different growth patterns for different types of melanoma, and hence different prognoses.
Llevaba 2 semanas sin aparecer y pues yo me fui a buscarlo porque estaba angustiada. Mire con las que me sale que él no volvía porque yo
So, a melanoma will exhibit all 4 or 5 of these things, the ABCDE criteria of clinical features. The A stands for asymmetry, because it has an uncontrollable growth pattern, will not appear symmetric in terms of its growth. Okay, so A for asymmetry. Again, this kind of alludes to the growth pattern. The border is going to appear irregular. Okay, it can have notching. So irregular borders. There's another finding. It's the B in the ABCD.
Oye, amor, ¿por qué no?
C.
No sé, para el cuarto de la casa de tus abuelitos, una cama aquí.
Tampoco llegó ese cancelo.
¿Qué vamos a hacer cuando nosotros vayamos?
There's color variation.
La casa de tus
Okay,
abuelitos.
so it changes in color in different areas. It can be brown, black in one area, it can be red, blue in another area, depending on the amount of melanin that's being produced, the amount and the depth of melanin that's being produced.
Tu cuarto se queda chiquito.
Ustedes me dijeron que hasta esta noche.
Pasan, le dije que vamos a ver el cuarto.
Ustedes. No las puedo tener más aquí. Así que miren a ver qué van a hacer.
Then we have D, diameter, which is greater than 6 millimeters. So anything greater than 6 millimeters is just the size of a pencil eraser. Again, more in favor of a melanoma than any other pigmented lesion. And E, which is evolving or evolution. The lesion will change in terms of, everything, size, shape, color, surface, and symptoms over time. Okay. So all of these findings, the ABCDE, are in favor of a melanoma. So just to recap, the physiological pigmentation we said was symmetric and persistent. Architecture of the gums has not changed. Intraorally, it's very commonly seen. There's an increase in melanin production. Does not exhibit any of the ABCDEs. It's not asymmetric, the borders are regular, color is consistent, diameter is the same, doesn't evolve over time. Okay, so this is physiologic pigmentation. Any questions on all the stuff we just talked about? Please let me know. Otherwise, we will begin the salivary gland diseases. Any questions then? So, salivary gland pathology, we will discuss it in detail. We're going to go on lunch break in a few minutes, yes. So, salivary gland pathology we'll discuss in very great detail, but initially we need to talk about saliva, salivary glands, salivary gland ducts, salivary production changes through time, and then we will get to saliva. So, the volume of saliva that's made per day usually varies somewhere between 600 to 1,000 milliliters per day. And obviously there's a big component, there's a lot of different things that are in saliva, okay? So One is electrolytes. So we have a wide range of different electrolytes that play different roles. Could be even, bicarbonate and like HPO4 needed for buffering and that kind of stuff. Fluoride for, obviously fluoride, anti sort of microbial properties. Secretory proteins that like amylases and proteases are involved in initial digestion, and other things that are like peroxidases, cystatines, lysozymes, which are more protective. This should be in your basic sciences on restorative. Some of the notes. Okay, hold on. That's my questions today.
¿Qué quieres?
Este frío que tengo.
Los fríos. Fría. Voy a.
Porque en la historia, ¿ves? Por eso no te dio canchita. Tú te eructas, después te duele todo en lista.
Ah, bueno, para su comidita, mi bebé.
Cosa.
Immunoglobulins, so secretory IgA and other immunoglobulins are seen. Organics, other components are present, growth factors and such. We'll look into that. And again, if you look at the functions of saliva, there's multiple functions that saliva plays, ranging from protective to digestion, like we mentioned, tissue repair, antimicrobial therapy, tooth integrity, and buffering, as well as taste. And each of these little active components inside the saliva will play a role. For example, water is in clearance. The different salivary glycoproteins and mucins may be present for lubrication. Buffering would be the ones that I mentioned, like bicarbonates and phosphates, fluoride, and other ions that may sort of maintain tooth integrity. Antimicrobial sort of things like, for example, lysozyme peroxidase, the immunoglobulins. And tissue repair, because we said there's growth factors that are inside saliva. Digestion, amylases, lipases, proteases. So the oral cavity obviously is the beginning of your digestive tract. So the initial digestion, formation of the bolus, all this stuff starts there. Taste, again, so with the different growth factors and different molecules, they will also lead to taste perception. So, in terms of the embryonic development of the salivary gland, it kind of goes up, down, right? So all the way down here. So initially what we have is parotid. Parotid develops in the 4th to 6th week of embryonic life. 4th to 6th. Submandibular 6, and 8 to 12 for sublingual. And now, in terms of the whole saliva, obviously they all contribute, but the major amount needed for resting saliva is submandibular, okay? Whereas stimulated is obviously carotid, okay? And then submandibular, okay? So the major flow or the amount of saliva, volume of saliva needed for resting is given by the submandibular gland, whereas the stimulated is mainly the parotid gland. The pH of whole saliva is something around 6.7 to 7.4, so it's pretty neutral-ish, whereas the parotid is a little bit more basic. So, parotid, obviously, we talked about embryonic, we talked about the contributions to the saliva. The position is it's in front of the ears, it's in front and below the ears, right? Submandibular underneath the mandible, sublingual below the tongue. Minor is pretty spread out in the cheek and lips. And if we're going to talk about the ducts and so forth, so the parotid duct, so these three are the majors, right? Parotid, submandibular, and sublingual. Largest one being parotid. And so this is why we discussed that. In terms of main source of salivary volume, means resting, okay, non-stimulated saliva, the submandibular gland is first, and then second would be parotid. Okay. But upon stimulation, it is the main source of saliva. The parotid gland typically has, so we have inside these glands, we have these secretory compartments or cells called acini, okay? And they're mainly serous in nature, okay? So a lot of sort of digestive enzymes and that sort of stuff, and more alkaline in terms of content. Okay, so it's serous acini. Okay. So pH is a little bit higher in stimulated saliva, more beneficial for oral health. Submandibular gland is the main source of salivary volume, second largest major salivary gland. It's mixed, so it has seromucous acini, so it has both mucous acini and serous. They create a mixed sort of sublingual, smallest amongst the major, purely mucus. So as you go from parotid to sublingual, it goes fully serous, mixed seromucus, and then fully mucus, and the secretory compartments. Okay, so very thick and high viscosity secretions with sublingual. Okay, so one more thing is the duct. So the parotid duct, the parotid gland duct is basically this one right here. It's called the Stensen's duct. And it just pierces through the fascinating muscle, comes out in the buccal mucosa at the level of like the molars there. On both sides. Submandibular gland has the Wharton's duct, okay? So the Wharton's duct that kind of pierces into the floor of the mouth. And sublingual has small individual ones called the ducts of Rivenus and the Bartholin's ducts. It's the biggest out of all of them. So they either go into submandibular or they will perforate into the floor of the mouth individually in the ducts of Rivenus. The minor salivary glands is also important for you to note. They're mainly labial and buccal, right? Which I've said are mainly mucus in terms of secretion, and they're located in the buccal and labial mucosa. Couple of exceptions here is the von Ebner's and the anterior lingual. So von Ebner is at the base of the circumvallate papilla. So remember the tongue was here 1/3 and anterior 2/3. They had these big sort of papillae there. And in the base of these circumvallate mushroom-shaped papillae, we have these glands, the von Ebner glands. They rinse away the food from the papillae. These are serous only, so it's an exception to minor salivary glands. Otherwise, they're all mucus. Another exception that's mixed seromucus is the anterior lingual glands, or glands of Blandin none. So it's located in the front of the tongue. That's mixed seromucus. Otherwise, everything else is mucus. So it's only glands. Now the ducts. So 3 main ducts that we have here, okay? So as you can see here, these are the secretory sort of acini that we were talking about, the compartments that make the secretions. They need a little sort of like pathway to leave the gland into their ducts. And we have 3 main ones. We have intercalated, okay, where you have that initial primary saliva that passes through it, okay, followed by striated. So intercalated was right after the acini, right? Goes into the intercalated duct, goes into the striated duct. So striated because they have these striations and these little lines in their cytoplasms. That's why it's called striated. The important thing that happens here is that we have reabsorption of sodium chloride and secretion of potassium and bicarbonate. Okay, so sodium and chloride is taken up, potassium and bicarbonate is given out. That's why saliva is not salty, because of this ion exchange that happens in the striated ducts. And lastly, we have the excretory ducts, which are larger in diameter, and the saliva has gone through some chemical changes, and now it's ready to be transported into the oral cavity. So through the excretory and main excretory ducts, it goes into the oral cavity. So 3 ducts, intercalated, striated, and excretory. So, as you start to age, after even 20 years of age, daily production of saliva will start to gradually decrease. Okay? You do lose a little bit of parenchymal tissue, so the main secretory tissues will start to be lost a little bit with age. So the volume will decrease. Some studies have shown 30 to 60% loss in the volume of the acini and major salivary glands. And sometimes these lost cells are replaced by either fibrous connective tissue or adipose connective tissue. And it's not really clear in older patients if this reduction in saliva is directly related to the loss of the parenchymal tissues or it's other factors. Okay, because studies suggest that even though resting saliva is normal in terms of volume, the resting saliva secretion is normal, the volume of saliva being stimulated is decreased. So the decrease is more so speculated to be because of a reduction in stimulated and not unstimulated. So the lesions that we will discuss today, I'm going to just go over the headings and then we'll take the break, are the reactive lesions, sialadenitis, adenosis, benign neoplasms and malignant neoplasms of salivary gland origin, as well as other lesions. So the reactive lesions we will discuss is the mucus extravasation phenomenon, or mucocele. The ranula, which is a flourishing of mucocele, salivary gland stones or silolithiasis, Necrotizing silometaplasia. We will discuss silodinitis. We did discuss mumps already, so we're gonna skip past that one. CMV, silodinitis, bacterial, and sarcoidosis as well. We will go through the neoplasms, so mainly the most common ones, so pleomorphic adenoma and basically pleomorphic adenoma and Warthin's tumor. It's not this list. These ones are pretty rare, but I think some of them may be in your notes if you want to study that. Malignant neoplasms, we will discuss the mucoepidermoid, carcinoma, pleomorphic low-grade, phenoid, cystic, and cynic cell. These two I think is in the notes, but not in the lecture. The most common benign neoplasm of salivary gland origin is the Pseudoadenoma tumor or pleomorphic adenoma. The most common here is the mucoepidermoid carcinoma. We'll go through this very extensively. And by others, we meant silodinosis, which are basically metabolic conditions where the salivary glands may be affected and there's no infection involved. Sjogren's, xerostomia, Taliesin, and IgG4 related disease. So we'll discuss all of this after the break. So should be good. So I think we should be good to take the break. That's long lunch break for 30 minutes. Come back, and then we'll go on with all the stuff that we have to cover.
Vale, chico.
Okay, so thanks you guys for joining us. Okay?
Cachosa la carachosa.
Voy a preparar tu comida ya.